In this particular hour, we have a guest in studio, and we want to talk about cancer, and it's such a burden in Kenya. We cannot stress this enough. It is a serious burden, and I want to have a conversation, or rather have a conversation with the people who are leading the fight against cancer. He is the chairperson, the National Cancer Institute. This is Dr. Timothy Olweny. Daktari, karibu tena sana to Radio Generation.
Thank you very much.
Nice to see you again after, I think now this is almost 3 months later.
Yes, it is.
The conversation we had here last time was awesome, eye-opening to some extent, because we got to understand the true picture of, number one, staffing as far as our institutes are concerned, the hospitals are concerned, and the real burden. And from where I sit, there's a small improvement we can do, and perhaps it will have a very huge impact as far as managing cancer in this country is concerned. Yeah, so karibu tena sana.
Thank you.
We had a conversation, I think, a while back with another doctor, and we were just talking about cancer specifically. And I think he mentioned the number one cancer that is currently killing women in the country right now. Is it breast cancer?
It is breast cancer, yes.
Okay. And it is, can I say that it is one of the easiest cancers to actually detect, because you just need to feel your breast to understand the lumps and to understand that something has changed within you, as opposed to other cancers where you need to go for tests and serious biopsies to get to know these particular cancers. Am I wrong on that?
Yes. Fortunately, there are certain types of cancer that are more amenable to preventive type treatment. So if we raise awareness amongst our population and do proper screening, high index of suspicion in terms of when people detect that there might be a problem, seek healthcare, to see your healthcare provider, we can be able to significantly reduce the number of deaths. And that's why one of the focuses that we have to maintain at this point is to ensure that we catch these things upstream. We make sure that we prevent as much as possible, and for those who develop cancer, detect it early and manage it early. And that's extremely important, especially in an environment like us where resources are very constrained. Yes.
Now, in terms of resources, the human resource is also a very big problem. And I remember when you were here, you told us that we have a very small number of oncologists who are even spread across the country. Kindly remind us of these numbers. I think you mentioned something to do with less than 100, or is it 100?
The numbers are small. Of course, it keeps varying, but the numbers we have are a drop in the ocean. It is way below what we require, and that's why I'm saying we need to be more innovative in terms of how we utilize the resources we have. First of all, maximize their use in terms of making sure that we empower the lower level personnel, and I'll say lower level with respect to expertise with cancer. Empower the lower level personnel so that they can be able to assist, to be able to identify these cases, and make sure we have a referral system that channels patients in a prompt manner to see the highest level specialists they can see, so that we can intervene early.
Yeah.
Yes.
Now, in terms of the doctors that are already in this particular institutes or clinics across the country, dispensaries and so on, is there a mechanism? And tell me, is there a way? Do you usually have like a WhatsApp group or a conference, or whether it's annually, biannually, or whatever, where you actually meet your fellow doctors and tell them, look, you could be an orthopedic surgeon, or you could be that clinician in that dispensary in Ushago, but these are some of the things you need to look at so that you can be able to disseminate this information to us to be able to help your patients better, especially if you suspect that they suffer from cancer?
Yes, there's professional forums, a multiple number of them. And these professional forums are there from the umbrella association, which is Kenya Medical Association, which is for all doctors. And then you've got all the specialist associations again. Now, one of the things which I really thank COVID for is COVID opened up this space about doing things online, even in terms of knowledge, in terms of meetings, and now they're much more dispersed. Before, it had to be that you had to be physically at a location to be able to dispense this knowledge. Now we've got knowledge which people are getting globally. People are on Zoom calls and meetings and so on with people globally. So in general, now we're able to disseminate this information amongst the professional communities much easier. And even the other level personnel, whether it's clinical officers, whether it's nurses and so on, everybody has got their professional associations, WhatsApp groups and so on. So communication is much better.
Yeah.
And in fact, access to information in this day and age of the internet and so on is so much easier. So we just need to be able to utilize all these resources and make sure that this information gets out.
There's a celebrity who passed on recently, and what they said that she was diagnosed literally a few days, or is it a few weeks ago, and she passed on. Is it possible for cancer to kill you that fast, especially considering that it was just a diagnosis she received? And for me, I was asking myself, was it like shock, or is it the fact that it was discovered much later in its advancement, and that is what killed this particular individual? Is it possible to be killed by shock because you've now been told you have HIV, for example? You were diagnosed with diabetes, or you diagnosed with cancer, and then when I realized by the guy naenda, and then you go.
Well, the mind is a very powerful thing. We in the medical community, I not say you get killed by shock as such, because shock in the medical terms and shock in the layman's terms are kind of different.
True.
However, one thing that I can say without being privy to the details of what transpired in her particular case is that you can also diagnose cancer when you have already developed a complication from that cancer. So sometimes you can die from a complication of the cancer, as opposed to, cancer
itself,
by definition, it spreads. So it can spread and, for example, spread to a vital organ and affect your organ function, and you die from that. So chances are it is very possible that it was diagnosed late. That's for sure. She died from a complication of the cancer, maybe not necessarily the cancer itself. Or there are certain types of cancer that are going to spread, and especially those where pain is not a significant symptom. It can progress significantly without you being knowing, and therefore without any knowledge, and therefore you end up passing away within a very short time frame of the diagnosis.
Yeah, because hers was literally within days of diagnosis. But anyway, like you've said, we really don't have details of that particular patient. But in terms of doctors again, how long does it take to train an oncologist?
It's a long time, because you do your basic degree, then most of the time you go in for your master's in medicine, and then after that again you subspecialize. So it takes a long time. It's a very long time.
Yeah? I thought when you master is that time when now you decide to become an oncologist, or a gyna, or an orthopedic surgeon.
Yes, the training takes and that's one of the reasons why we actually don't have sufficient numbers of specialists, because it takes a lot of serious academic commitment, and it takes a lot of time for people to be able to get to that point. Then also, of course, it has to be that when you enter a certain field, you see there are different motivations for people to go into certain fields. So it has to be one where somebody again also feels that you get the job satisfaction and so on. That's why it's very important for us to be able to provide the tools for our specialists to be able to do what they're trained to do. Because it becomes frustrating, for example, when you go through that duration of training, and then you get to a point where you don't feel like you don't have the tools to be able to apply your trade, so to speak, and therefore you don't get the job satisfaction. And that's why, much as, for example, monetary compensation is important, making a difference for most people, and especially doctors, is extremely important. So you have to feel that you're getting satisfaction from your work and you're making a difference.
I did a unit in campus called tumors, because I studied biotech at KU, and it was 3 months, and I came out there thinking, now I know so much about tumors and cancer. And now you're telling me that it takes much more. And this is before I even understood the kind of training that doctors usually undergo to become whatever areas of specialization they have. But one thing I understood from that particular class is the fact that there are very many ways of skinning a cat. And by this cat, I mean tumors and cancers. One way is gene therapy, and I actually got interested in that line of academia, and I went in and I started looking at different options and different things that we can actually do and achieve. Is it possible to actually first of all, do we have that in this country? Gene therapy that is actually centered on treating tumors and cancers?
Yes, we do. Let me tell you, one of the things that people don't understand is in this day and age, the dispersion of knowledge is actually very fast. It's not like in the 80s and 90s, for example, where technology would develop in the developed countries, so-called developed countries, and take years for it to get here. You must remember, purely even by virtue of the fact that a lot of our specialists are even trained in those developed countries and keep contact and keep updated in terms of information. So in general, those resources are here. One of the things I'd like to debunk, and one of the things I've been emphasizing even in talks that I've been doing the last few in the recent past, is that we talk about, and I've said even that for us who are in this space, we have caused a little bit of confusion by talking about cancer as if cancer is one disease.
Yeah.
Cancer is actually a group of 100 to 200 diseases, right? And I say this because cancer has very many different types. Any individual organ or tissue in your body, any cell that divides can potentially develop cancer. All right? And so when we talk about cancer, whether it comes to issues of treatment, and so when you say, for example, cancer seems to be has become such a huge problem. All right? All right, it has to be with the view of saying these 200 diseases have become a huge problem. Not one. But secondly, when it comes to interventions, and that's why you see, for example, when you talk about the issue of training, you can see how difficult that is,
yes,
and how it spans so many different specialities, because it covers everywhere. You can get cancer. By the way, the only dead cells, for example, your nails, your hair, and so on, and maybe the enamel of your teeth, are the ones that cannot develop cancer.
Anything else?
But anything that divides, and the more likely, the more rapidly any cell divides, the more likely it is to develop cancer, because things can go wrong. The more you do something, like cell division, for example,
yes,
the more likely something will go wrong along the way. You know, we got this presumption. So often, by the way, in the human body, things go right, and we take it for granted. There's so many complicated things, even as you sit there and movie, that are going on in your body subconsciously. You're not even aware of them. The moment something goes wrong and you have a headache, you're like, oh, yes. But in fact, we should actually be surprised that it goes right almost all the time. All right. But in terms of, even when it comes to compensation, and I know there's been a huge push about there not being sufficient compensation, especially on the social health insurance programs for cancer and so on. I said we need to break down this thing and accept we're not dealing with one disease. So you can't have blanket compensation, one figure for all these diseases. How about, for example, we just break down each individual disease and say, this is the tariff, this is the amount we need to compensate for this. And I know it's a huge exercise, all right? But how about we start with the big five? The big five cancers in Kenya are breast, cervix, prostate, colorectal cancer, all right? And I'm forgetting, I've said breast,
cervical?
Cervix. Yes, breast, cervix, prostate, colorectal cancer. Right now I'm even forgetting the fifth one. However,
colorectal ni gani?
The one for your lower part of your colon and the lower part of the alimentary canal. Yes.
Right.
But now, if we can be able to just, and esophageal cancer, that's the fifth one. Now, if, for example, this makes up, for example, 50% of the cancers we have, how about, first of all, we focus on prevention of these five, expend our efforts in terms of preventing them, and then again in terms of managing them effectively, and lastly and most importantly, compensate them adequately so that we know each of the, that will reduce the amount of hue and cry that we have about people saying compensation for cancer treatment is not sufficient. There are times when, for example, you might say we are giving 550,000 for every case of cancer. There are times when, by the way, that 550 is actually excessive, depending on what type of cancer it is, at what stage it is found. And then there are times where that doesn't even scratch the surface. Some people are going to exhaust that purely before they get the diagnosis. They've exhausted their benefit. So those are the things that we need to actively engage in. Those are discussions we're having with the relevant
yesterday we were talking about the East Africa community, and we were talking about the spirit of our Jumuiya. The Jumuiya comes together and decides to do several projects together, for example, railways and road networks. Is there a conversation about health that you know of, because I don't know of one, where all these East Africa countries can come together and say, look guys, can we pool resources and build maybe like 5 major hospitals across the region that will just take care of cancer, and we give enough resources? Because if you look at the resources they put on roads, for example, it's in the billions, railways in the billions, ports and so on, and they collaborate on such issues, billions. Is there a conversation that you know of that actually focuses on health, and they say, in East Africa, this is our problem, the 5 cancers, for example, you've spoken about, and they say, let's set up some very nice centers that are accessible to all members of our Jumuiya, and they can get treated in these centers at an affordable rate, some kind of SHA for the East Africa region.
I'm not aware of any such initiative. One thing I know that would be a challenge here is, even if you were to set up a center and say it's a center of excellence, it would mean, if it's a center of excellence that's set up in a particular country, it would mean literally the people from the other country coming to be able to access care.
That's exactly
medical tourism, so to speak.
Yes.
In general, every single jurisdiction, for example, would want to be able to have their citizens not traveling out of the country to be able to seek treatment. And remember, I'll go back historically. And CT might know, there was a former vice chancellor called Professor Mungai, who I talked to once.
He was a medical doctor.
Yes. And I talked to him once and I asked him, this thing about medical schools, how did we end up with this situation where, for example, we had a teaching institution a medical institution, a teaching institution not owned by the university, that looks off because most of the countries you'd have them combined. But he said originally, in the original East African arrangement, it was that they had the different universities kind of specialize in different specialties.
Yes.
So University of Nairobi was supposed to be more for engineering, law was in Dar es Salaam, and for example, Makerere was mainly law, medicine.
So Dar es Salaam law and so forth.
Our first president, Kenyatta, realized with the kind of quota we were given, there was no way we were going to get the kind of medical professionals that we required to be able to develop our country and to take care of our healthcare. So that's how this arrangement came and said, let's start doing medicine in Nairobi. And that's the story he gave me. But you understand how now regional interests. So at the end of the day, this contract issue of medical tourism, it means foreign exchange moving back and forth. There's a lot of movement of people. So in general, I'll call it a selfishness, which makes sense. There's a selfishness with every region, kind of saying let's focus on improving our lot. If other people want to come, let them come and access healthcare in our region. And especially for Kenya, since I'm sure we perceive ourselves, and I believe it's true, that we're ahead in terms of the medical, it would mean, for example, there's no way we would say let's go and set it up in a different country. We're like, why? We're the ones with the professionals, we're the ones with more resources and so on. So I'm not aware of such conversations, but at a professional level, there's a lot of collaboration. But however, in terms of infrastructure and other resources and having that concentrated in particular regions,
the thing is, the question he asks has an answer to it in very simple terms. You will find that the universities in these various countries actually collaborate. You will find that, for instance, when you talk about visiting teachers or professors or visiting examiners, they exchange. There is an understanding. If it's research, there are consortiums that collaborate within East Africa. Remember, the union that we have, for it to get to a point, because what you're saying would suggest a political union. That is a hard sell. That's a very, very hard sell.
But we already collaborate on roads, we collaborate on railways, we collaborate on...
You're not listening.
Okay.
It is a hard sell because the country then loses their autonomy. Look at the EU. They have a common visa. They have common boundaries. You can walk throughout any Europe once you have that Schengen visa. But each country is run politically as they see fit. They have certain commonalities. Nyerere said this when he said, we ought to have delayed our independences, the three countries, to talk about that political parity. We did not. So even as we had that common understanding of what we wanted, because we all these things we're struggling with, we actually had them, and we could have continued just building on them. The shilling, the Tanzanian shilling, the Kenyan shilling, Ugandan shilling were on par. The issue of Kenyans going to school in any of these countries was normal. As I said, we had gotten there. These unions that you speak of, even when you have a body like the USSR that essentially was a colonizing body, that is when you have that sort of commonality. But if you have nations, individual nations seeking to work together, the thing that they will achieve easiest is that economic parity, because it helps trade. What you've done is you've opened up trade to a much huger area, a much bigger population, and people stand to benefit. They may even have exchanges in terms of education process and programs. Politically, it is a hard sell. It's an extremely hard sell. You could argue that you could follow the Swiss method, the rotational method. But the rotational method works because the president, which is a rotational position, is not really powerful. It's more ceremonial than anything else. So that could work. But if you cannot even get the economic partnership working as you should, how do you think you'll get the political one to work?
Just even to emphasize my point further, has it ever occurred to you why, for example, cancer doesn't get the same attention as Ebola would, or as some other outbreak of
call it let's talk of HIV.
Yes, right?
Yes.
The reason is when you talk about global health security, now other people are actually funding your activities and deploying resources.
Yes.
But why are they doing it? To protect themselves from you. In other words, they don't want you to get the problem to them. And for example, COVID brought this out in the worst possible form. It got to a point where people just locked their borders. because now they said you can't bring us this problem. Even in the Shenzhen area where we got a visa, where people can travel amongst 30 countries freely, that issue ended with COVID, because at that point every country now is looking out for its own. And that's what I'm saying. At the end of the day, each country looks out for itself. So even for us as a country, whether you like it or not, we must be able to get our act together and make sure we can be able to manage this to the extent that we can. Then if other countries want to come and be able to benefit from our system, let them come and benefit from the resources we have. But in terms of cooperation at this regional level, right now, if you ask me, I think we are at our lowest in terms of cooperation, in terms of getting along. Yes. So it's even more difficult.
But could it be a good idea?
Hypothetically. Let me tell you, it would be a good idea, because one of the problems that we have is you cannot have, especially where resources are limited, you cannot have everybody trying to do everything. You will be able to do it to a certain extent, but you can't get to that super specialized level where we've got a center of excellence. So the best way to do it actually is to have people focus, like you're saying, on particular areas. We have got an institution that focuses on childhood cancers, another one that focuses on different type of cancer and so on, and then you have people being referred as and when required. That would be ideal. But in practice, it takes a bit more, because like you're saying, there are political components to it. There's a lot of things that need to be put together before that works.
But look at, say, for instance, the US. Which has states that one could argue are semi-autonomous, and they have a central government. And they have a model that you can look at and you can see how this thing would work. But still, each state will have something that they're particularly good at. Now, you could argue that these things have morphed organically, but again, it is their business model and the thinking of how they want to run the economy that has brought this about. And this is something that has happened over centuries. Okay? Perhaps an even better example would be Canada. Okay? But you see, these are countries that by virtue of their existence had an understanding that they had an enemy that was far away in Europe. Okay? So even when they were forming themselves with one understanding they were going to be different from wherever it is that they had come from. And each of them was focusing on how they can make the little unit that they have. Now, the unity that then formed Canada or the US came later. They realized we are better off fighting these people if we work together. So they've and they keep improving on this same thing. Remember, we have a fantastic problem here. Even our political processes are different. Those fellows had more or less the same sort of political. This one, completely different. Okay? Tanzania were essentially socialists. We were not. Us were capitalists from the get-go. Uganda were capitalists. Then they had a monarchy. Then they had. It's an interesting mix. The other countries I will not mention because I'm not certain what they had. Some people had monarchies, some didn't. But if you are talking about a formation that benefits the citizenry. What we have works, and I'm going to tell you why it works. When there's an element of competition within countries, then you are in essence promoting excellence without necessarily saying we want to promote excellence, because you want to be the go-to people when it comes to certain things. Why is it that Tanzania has been a challenge when it comes to tourism for us? Because they have the same ecosystem as we do when it comes to tourism, same animals, because those animals don't know these boundaries. Okay? But the way they're structured there is one, they allow big game hunting. It's controlled. They allow certain things. They don't cost as much. So they will have people going to their country, people who ordinarily would have come to our country. Now, if you are talking about trade, how is it that Uganda is our biggest trading partner? How? They're smaller than us in size. We are more than them. These are things that have morphed for this simple reason that that Terry mentioned. There are things the Ugandans do better than us. The bulk of their country is arable. Ours isn't. Ours is only probably 30% that you can argue is arable. So they're able to produce food far, far better. And their policies are far, far better when it comes to some of those things than ours. So we'll end up importing more food from them, and yet we produce the same food. Some of these things, it is in our interest to actually probably have certain controls, but let them morph organically. People who understand business and are engaged in business tend to find an even playing ground for themselves. Yes.
Okay. Daktari, you posted recently on your X that you shall be hosting the 2027 World Cancer Leaders Summit. What is this all about?
Well, this Cancer Leaders Summit is an extremely huge, one of the largest events in the cancer ecosystem in the world, and it brings together all players in the cancer, all leaders and all players in the cancer sector, whether it's in respect to funding, whether it's professionals, and so on. So it's a very big opportunity for us to be able to bring all these leaders together in one place. We're going to be hosting them in 2027. It's supposed to be, I think, in November of 2027.
Yeah, it's 24th to 28th November.
Yes, and so that's what we're looking forward to hosting. In fact, at the moment, we've got the summit going on in Australia as well. So it's also a good opportunity for us to be able to meet the partners, the sponsors, and the different players in that sector, and also set the stage for us to be able to host in 2027. So we're hopeful that with that big event occurring, it will bring a lot of focus for cancer in terms of Kenya, and bring improvements in terms of how we manage it. Yeah.
All right. We've also seen a rise in cancer cases, especially in our country right now. What would you attribute that to?
Well, if you want to talk about the rise in cases of cancer, it's not necessarily even just a Kenyan problem. It's actually a global problem. And if you look at the etiology or the causes of cancer, you realize that cancer is, first of all, there are certain components which you can do nothing about, and we call them non-modifiable. It's got to do with heredity to some extent, genetic predisposition, your age. As you grow older, you get cancer, your gender. If you're female, you're more predisposed, of course, to certain types of cancer than males, and so on. So those we don't talk about too much. Those are non-modifiable. But however, we have to increase awareness amongst, for example, healthcare providers and the population, so that you're able to say, I'm at risk of this, and therefore detect it early. Now, the other causes are things called carcinogens. Anything that increases, for example, can damage your cells. So we've got carcinogens, things, for example, like radiation, whether it's X-radiation or UV radiation from a nuclear plant, or you've got certain chemicals, pesticides, things in your food, sugar, for example, in your diet. Those are things, and things like obesity, limited exercise. Now, those are increasing as we become more westernized. Unfortunately, the developed countries are experiencing that even more than the West. So as much as we're talking about an increase, there's a disproportionate increase amongst low and middle income countries compared to the developed ones.
Yeah.
To compound the situation further, the deaths, the proportion of people who have cancer to those who die is even much higher again in our countries. And that's why it becomes important, like I said, that we have to look for ways of being able to prevent, as opposed to waiting for people to get cancer and then treat them.
Yeah. All right. Lawyer Donald Correll did say that, funds have been cut. Let me just read that. He said, due to overwhelming response I've received from friends and strangers, I wanted to suggest that we all support National Cancer Institute as its budget has been substantially cut. What did he mean by that?
Well, I don't know whether that has got a factual basis. I think what he might have meant, and I remember having a conversation with him a short while ago.
Yeah,
it is more to do with that we don't have sufficient resources being deployed in terms of cancer care. So whatever amount of money that we can get in terms of additional support would be welcome. Yeah. All
right. So when you're talking about additional support, apart from the government, who else is in a position to actually support NCI?
We've got a lot of partners who support NCI. You've got various people. For example, you've got a lot of people who are partners, whether it's pharmaceutical companies, people who are involved in research, people who want to fund specific programs relating to prevention and so on. Yeah. So we've got a whole array of partners, and one of our roles is to be able to coordinate all these efforts, because we've got so many players in this sector. But the key thing is for us to have coordinated efforts, because there are places where you've got gaps, for example, and then there are places where we've got duplication of roles.
Yeah.
And our role is to try and make sure that we have got these things to coordinate these efforts so that it's within the national best interest and it meets our needs. Yeah. So that's in essence what it is.
Can private citizens such as myself and CT say, I'd like to support NCI?
Yes, you can. Okay. You can, and you can in different ways. It is not even an issue of saying that, for example, you have to give us financial support directly. We can be able to help you and direct and work with other partners to be able to have initiatives. For example, you've got funds, like for the ones my friend Donald Kipkorir has got. You can be able to dispense them and say, I want to invest this in terms of promoting screening efforts.
Yes.
All right. So we'll be able to direct you to a place where we feel there's more need. For example, different types of cancer have got different preponderance in different counties. So, for example, we say this is where we feel there's a gap. We direct this effort. For example, you can buy a certain piece of equipment, some screening equipment. So there's always a need. And for us, we can be able to help people and also align it with what their objective is. For example, you've got somebody whose relative or parent died from a particular type of cancer. He might be saying, no, I want to dispense deploy these resources with this particular type of cancer. Then we'll be able to provide the assistance.
Yeah. There's always a discussion around preventative and promotive health care. With regards to cancer, how exactly would this look like? If we were to promote the preventative aspect of healthcare in the arena of cancer, how would this look like?
Well, one of the things that I feel very passionately about is that we first of all have to integrate preventive and promotive care in cancer into our regular management programs. It cannot be that it's an occasional effort or one where it's an ad hoc where we say we have got this World Cancer Day on this day and we go and do screening in a particular county. I want it to be that any healthcare provider who sees you for whatever reason, I'll use the term profiling in a good sense, will profile you and say this person is at risk of this cancer, and actually ask the question, when is the last time you had a PSA done? When is the last time you had this done? It has to be part of that care. But you see, the thing is, again, I always am a firm believer in the concept and the principle that what you incentivize happens. The difficulty that we've had is in the absence of these efforts being funded. You see, in a place where people are struggling to meet their daily needs, there's nobody who is going to have the opportunity cost is, do I put food on my table today, or do I spend this money screening for an unforeseen event? The choice is going to be very clear. So it has to be that we have got to fund these efforts so that we're asking people to go for screening, but somehow that is funded. And that's one of the things that we're in discussions in, because in the absence of us funding preventive care, we are again going to the same trap of saying we are going to dealing with things downstream where it is more expensive, outcomes are poorer, and the effects in terms of socioeconomic impact and so on are even much greater.
If you were to integrate this, and given the way we've structured our healthcare at the different levels, at what level would you be able to start screening?
Primary healthcare, at the primary healthcare level, at the level of the dispensaries and health centers.
You are able to actually screen at that particular level?
Yes, but we've got to deploy the resources. That's what I'm saying.
Okay.
Yes.
What does it take to have the resources that would actually enable you to have the screening?
If you ask me, the resources are there. I think it's an issue of prioritization, right? And prioritization, one of the things that I know for a fact is we have got this thing called government at the moment. And government in Kenya is actually not just one government with respect to healthcare and how those resources are deployed. It is actually 48 governments, because we have 47 counties and health is a primarily devolved function. So you find national government in terms of health institutions itself runs only the higher level institutions, the referral institutions as they are called. So now you find that the individual counties are the ones who have got to again prioritize the care in terms of and how they deploy the resources. And there has to be sufficient emphasis at that level for them to give focus to primary health care.
Yeah. Muhammad Hussam is asking why you blocked Donald Kipkorir on your X account.
I think those are technical issues, and I think our people, the teams who are handling, I think it was an accidental thing. I don't know what the details are because I don't run the X accounts,
right.
But it was an accidental thing, and I think an apology was made appropriately. I don't know how that happened.
Yeah.
Yes.
All right.
But there's no reason, by the way, why as the National Council would block anyone.
Yeah.
All right. Our approach, and mine especially, is that we have got to take all views. We have to listen.
Yeah.
Because when you're in any leadership position or any position where you're supposed to have an impact that is supposed to affect people's lives, you have got to get feedback from them. And so there's no way you can block. There's no reason for you to block anyone. Whether somebody says some unsavory things or not, you want to hear them.
Yeah.
Yes.
All right. I hope Muhammad umesikia yo mambo eh? All right. Next question is in regards to, let me just find it. Ilikuwa iko hapa tu kidogo. Why is it's about chemotherapy, and apparently chemotherapy makes the situation worse as far as cancer treatment is concerned. Is that I mean, could you say something about that?
Somebody asking that question, if chemotherapy makes it worse.
He seems to be stating it. He says it makes it worse.
This is the question. People saying chemo makes the situation worse.
Well, let me. You see, one of the things that people have to understand, and I think I alluded to this earlier, when you're talking about cancer cells, it's not cells from a different planet. These are your own cells. Now, if you've got anything which is going to attack these cells because these are your own cells that have gone rogue.
Yeah.
If you've got anything that is going to try and hammer them, it'll hammer them, yes, but it's also going to affect your normal cells. So it has got toxicity. So when it comes to chemotherapy, it's about risk benefit, right? And that's why it's also important. That's why the professionals are there, because they're going to assess and decide who needs chemotherapy and who doesn't. And at what point do you give chemotherapy and at when do you stop? when the harm seems to be becoming more than the benefit. So chemo is toxic drugs, and that's why the moment you get it, you've got side effects. So it makes the situation worse in certain ways, and I will not say situation worse. Overall, it should make your situation better, but it has side effects, and those side effects is what we weigh against the benefits.
I actually remember my mom went through chemotherapy, several cycles over a very long period rather. One thing I noticed is that she was very weak, especially after chemotherapy, and she had nausea most of the time, a few hours, not few, very many hours after chemotherapy. I can't remember the other symptoms. Oh yeah, her skin also darkened, and these are some of the side effects you're talking about.
Yes.
The chemotherapy itself, as you've said, is literally putting poison into your body. How is it able to differentiate between the good cells and the bad cells?
Well, the bad cells tend to, in general, to put it simply, the bad cells tend to divide much faster. All right? Therefore, they're going to be affected more than your regular cells. But your regular cells, the faster they divide, the also more likely they're supposed to have these side effects. For example, in the alimentary canal, cells are dividing and eating every other day, so gastrointestinal and alimentary canal side effects are going to be also more common. Your skin is also has got cells that are really dividing very fast, so it's going to affect your skin. So the faster your cells divide, the closer they look to cancer cells in a certain way, and therefore they're going to be a little more affected. But this, in general, I would not want people to have this misconception that chemotherapy will make the situation worse. Otherwise, we wouldn't give it. Chemotherapy is supposed to make things better. Already we have a bad situation. Can we be clear? We have a bad situation. We're trying to make the best of that bad situation. Therefore, we're giving you these drugs which are giving you some benefit, but they also have side effects. But the key thing here is to know that not everybody will benefit from chemotherapy, isn't it? There are going to be people who can benefit from chemotherapy. There are times, I keep saying, it's better to also not do anything.
If you consider, for instance,
if for example, if there's no perceived benefit, then there are times you also have to pull back and not do anything. So there are going to be times when, if somebody gets treatment that is inappropriate, then is when you can say it is making things worse. But in general, chemo makes things better.
So how do you tell the patient that hii yako sasa hatutafanya kitu?
You know, that's what I'm saying. There's a lot of things about, and this is why management of, for example, chronic and terminal illness is a very tricky thing. It's a very emotive subject because there's a lot of psychosocial effects. Because everybody, I keep joking once in a while that all of us are terminal because all of us are going to die, isn't it?
For sure.
What you don't want, what we're trying to avoid is premature death. And when you've got a life-threatening diagnosis, you see that death is imminent, right? It's closer than you would have imagined. And that's why it becomes a very emotive issue and so on. However, how you walk with patients through that journey from the time of diagnosis to the time of getting to the treatment and so on, if you walk this journey together, then ideally people should be within the mental frame where they are clear that this could go either way. And there are going to be times when we are going to tell you we need to stop the treatment. However, that is not the same as saying you're abandoned. There's a realm also called palliative care. It doesn't mean that if, for example, definitive treatment directed against your cancer cannot continue, it doesn't mean that there's nothing that can be done to help. What we focus on is quality of life. And that's what becomes important. That's why even when I'm saying the issues to do with chemotherapy and so on, it has to be clear that are we going to actually make so-and-so's life better over the time when they're getting the chemotherapy? The quality of life better? Are we going to prolong that life and make it good quality? If the answer is yes, then. But again, you have to involve your patients. And that's where patient autonomy is extremely important because patients have got rights. You give them the full information and they make decisions. There's a friend of mine who's had an auntie who was 80-something years old and got lung cancer and had smoked all her life. And then was being told, let's start all these treatments and so on. And she said, no, I'm not having it. And continued smoking and went on and lived her life and got into palliative care and so on. Those are choices people make. And I don't blame her because at the end of the day, it's a question of quality of life and how much life do you have left. But patients have got to decide themselves. They have to be involved in that decision. And so it is a difficult thing. It is going to be difficult when you tell a patient that at this point, we don't think any definitive treatment is going to benefit you, and then you move them on to other forms of care.
You know, in HIV and AIDS care and treatment, one of the things that was problematic, especially when the narrative around it was that when HIV positive, you're going to die. And they didn't mean that you'll eventually die like all humans, that you'll be dying soon. Okay?
Yes.
So there was need to train people who are in that particular ecosystem counseling. Among the things they counseled people in was something called adherence counseling, because you are given drugs as though you are a pharmacy, and people get fatigued. You get tired of taking this thing every day. So what would happen is there's an entire process of counseling. Even from the time you come in, you're being tested. There's pre, there's post. Part of the reason was because it was understood that when results were given and somebody was positive, their reaction tended to be adverse. People didn't react calmly. They reacted in the most dramatic way possible. Now, something like cancer, which doesn't come with stigma, perhaps doesn't carry that same weight. But again, some of these problems goes back to one, the curriculum that we have when we're training our healthcare providers, and how it is we feel that we need to approach this. Number one. Two, when you integrate something of this nature, because HIV care and treatment at some point had a similar discussion. How do we integrate this so that it becomes? But the issue was also one of confidentiality when you have tested. Now, for people to understand confidentiality, you need to train them again. Correct. So that they understand confidentiality. These are all doable things, because the lessons learned when treating and looking at one condition can easily be carried on to another. Cancer was not an issue, but it became an issue because we started finding cancers that were directly related to HIV. But usually somebody was at probably stage 4, meaning this disease was advanced in your body. Primary health care, if one understands what it's supposed to stand for, is probably the most cost-effective healthcare that one can actually undertake. Why is it that we always talk about it, but we do not actually focus on it? And yet, we've had studies done to show what it does and how it is that when it's effected, when it's put in effect, the attendance of the higher level hospitals is reduced significantly. Why? You are in a position where people make policies for such things. Why is it that something that we know would reduce the cost of healthcare as we know it, would help very many aspects of healthcare, it's the one thing that is spoken of but is not effected? Why would you think this is the case?
If you ask me, it's one of those things that has required a policy shift. The issue of primary healthcare is not new, by the way. It's been talked about, I think, from 1978 or something, where you had a policy paper that promoted primary healthcare, and there's very good underpinning logic as to why it is important. The reason why, if you were to ask me the reason why it has never been prioritized in the past, I think the tendency has been when people, first of all, are scrambling for resources, then people tend to deal with the people who immediately have got the problem. So your focus becomes those who are already afflicted as opposed to preventing this affliction. And even from a national and policy level and the political level, that's what it's good. It's the same problem we're having with cancer now. You've got cancer being such an emotive issue that the focus has got to be those people with cancer who have it now, and we need to treat them. And then we deplete all the resources. But you're not thinking and saying, how about we stop ourselves from getting here? That's why there was supposed to be a healthcare financing policy shift, because, like I said earlier, what you incentivize happens. In the past, we have purely funded treatment. And even if you look at medical institutions and so on, nobody pays anybody for preventive care. When somebody comes when they're sick, they're treated, that's what people bill, and that's what is paid. So what we need to do is a shift now and say we finance primary healthcare and incentivize people to engage in primary healthcare type activities, prevention and promotion of health. Then that way, down the road, we'll get the benefits.
Okay, let me take you further back just a little bit. This is in ancient times when you trained as a doctor. Public health, how many units did you study and for how long did you study it? Yes, you know what I'm asking.
Yes.
Precisely, because if at the level where you're training these healthcare providers, it's the one course people feel they can miss.
Yes.
It's the unit that gets the least attention. And yet, it is the unit that is supposed to help us actually fight the burden of disease at the very onset.
And unfortunately, like I say, even during the times when we were doing, when we were in medical school at that time, it was not really an seriously examinable subject.
No.
It was one where a lot of people would even skip class and go and study more serious, what we perceive as more serious subjects.
Exactly.
All right?
Now, see.
And so that's what I'm saying. It's in terms of mind shift and focus. And I remember, by the way, I was telling a colleague the other day, there's a friend of mine who was the pioneer class in Moi University when they started doing community medicine, and there was community health, a strong component, and they used to ride bicycles and go to the community, and we really laughed at them because at that time we were University of Nairobi, and we are the University of Nairobi. And so we've got all these other universities now that are starting to do things that are so out of character. I'm like, what kind of medical school is this you've gone to? Now when I look back in retrospect, I'm like, wow.
They had it right, didn't they?
They had it right.
Yes.
Right? So it's in terms of the focus, and that's why I'm saying over time we have got to shift this. And even when it comes to the financing, it is extremely important that we deploy our finances. That's why that primary healthcare fund, for example, under the new bills that were introduced, has got to be capitalized sufficiently. That is a high priority, and especially for cancer, one thing I know is that one thing we're going to lobby and say is even if funds are not sufficient, it has to be that we fund primary healthcare, and especially for prevention and control of cancer. Otherwise, we have got this model totally upside down. We're not going to make a dent in this cancer. Because let me tell you, if you've got a condition where you have 75 people dying every single day, you know, road accidents, when people die, 10 people in a matatu once in a month, for example, and so on. It is tragic and it gets so much attention. But here we've got 75 people because they're dying in different locations, and they're dying, I'll use the term quietly. It's not quiet, by the way, for the families who are involved, but it's quiet because it doesn't make the news and it doesn't do, and so on and so forth. But we've got 75 people dying every day from cancer in this country.
75 every day?
Yes. Annually, we have 27,000 deaths. And that might even be an underestimation because there are going to be some who are not picked up with diagnosed as cancer and so on, isn't it? So we have got a big problem on our hands, and it's very important that we put our minds together, be able to optimize whatever resources we have, use them adequately, but make sure we have to control this scourge of cancer, because all projections are it is actually going to even get worse.
And I recently discovered through again conversations here that there's a country where it's mandatory to vote. Was it Australia? Australia, where it's lazima. And I know this is a very radical question, but is it possible to make screening mandatory in this country?
Yes, you can.
Like we make ni lazima.
Yes, you can.
It's not a request.
You can. You can. There's really nothing stopping it. You actually can. But the thing is, for it to be effective and for it to be useful, you have to do a little more than just making it mandatory. See, people need to understand why you're doing it.
Because when I look at the burden on the economy for cancer, I mean, it's first of all from an individual level. Then you look at the family, how it's affected economically because of cancer. Then now look at institutions, hospitals. And I feel like the burden is just too much. If we're able to predict that so and so have got cancer and we detect it early enough, I feel like that burden can be reduced, specifically on matters to do with money.
Let me tell you, the focus you speak of, when you look at diseases that have had that focus, the results have been fantastic. I like talking about HIV because I worked in that field for a long time. And I saw. So this is not me being told, because I was participating in that process for something like 17 years. You get to see and understand very many things very intimately. And you actually see what it is that this issue, we talk about public participation in our politics and policy and so forth. In community engagement, as we refer to it, when people understand why it is they are doing what they are doing, they adhere. And when they adhere, the positivity of the results just keep increasing. And that is the reason why you would find, for instance, the modeling, you would find peers, okay? Who are peer educators? People who are HIV positive, they are on treatment. They are the ones who'd hold sessions talking to other people and they with their medication. Meaning, apart from just propagating the information about it, but you reduce the stigma because someone is telling you, look, I am also HIV positive and I'm on this. And we got to a point where you could be having a discussion with someone, not in a hospital, and someone tells you, give me a second, I need to take my medication. I am on these drugs. It means that particular stigma had reduced significantly. Cancer is a much bigger problem. HIV had funding from PEPFAR. So the burden was not on the Ministry of Health. This one is different. And the numbers are growing. It's very different. There is no PEPFAR-like institution giving funds to deal with this disease. So it will be felt very directly. So the need to have that focus on this primary health care is greater than ever before. And as Dr. Ria said, if it's policies, if it's research that has been done to show that this thing works, they have them in plenty.
Yeah. So, Dr. Can we make it mandatory? The logistics alone.
I can see where you're coming from with that request, and it makes a lot of logical sense. However, from a political perspective, from a human rights perspective, from a legal perspective, I can see how that there'd be challenges.
Okay.
So for me, I never advocate the aspect of mandating something. I believe, though, that if we're able to disseminate the information and convey what benefits there are, then people should be able to latch onto this. But latch on this and do it voluntarily. However, it also has to be funded, because when resources are restricted, you're not going to make something mandatory, for example, and somebody says, I just don't have the money to do it.
Yeah.
So, you know.
Dr.
Yes.
Taxes are mandatory. Does Kerry go around explaining to people why they must pay tax?
But do people still pay? Even do people pay those taxes in full? Even taxes people don't comply with.
Daktari, there's a question here. GVic anauliza, take a cancer that affects men, pick any. How do we prevent it? Regular screening? Is it diet? Is it lifestyle? Walk us through 5 things men can do to prevent the most common cancer affecting them.
Men, the most common cancer is still going to be prostate cancer, and that, for example, is one of those things that you become more likely to develop once you get to a certain age. So the risk increases with a certain age. The screening test, for example, with the test they call the PSA, which all men above a certain age, especially by the time you get to 50, are supposed to do. Before the recommendation was for more, I'll use the term invasive testing, in terms of digital rectal exam, which is what people did not particularly like. But there are ways of being able to manage it, and you just do a regular PSA. Now, there are certain things you become predisposed to at a certain age, like I said. So for men, it's fairly straightforward, and that's what I'm saying. Those are the things people need to do. You've got always some hereditary component, I'm sure, comes in terms of if you've got family members and so on who had prostate cancer. But you should assume, for example, that you're more likely to develop it. So it's just those things of basically seeing your healthcare provider and doing the testing.
So basically, what we're saying here is screening is the best way to detect and prevent these cancers.
Because let me tell you, if you detect cancer at a stage before it has spread, the outcome is always so much better. Because, for example, technically you can go in surgically and remove that entire piece of tissue that has got a problem, and you are cured, so to speak. The moment you get to a point where it has spread, and the further it has spread, the less likely. So, for example, surgery doesn't become an option; it is spread all over your body, because how do you operate on somebody's whole body? So, localized treatment is always the best thing, and it can only be done when it's in the early stages.
Yeah. All right. Thank you so much, Daktari. This is where we come to an end as far as this conversation is concerned. And as usual, we always appreciate your insight. But this is where we come to a close. That is Dr. Timothy Olweny. He's the chairperson of the National Cancer Institute.